I'm Dr. James Castillo. I'm the medical director for the Palliative Care Consultation Service here at Valley Baptist. I've been here in Harlingen since the Regional Academic Health Center opened up. I was in the first class of internal medicine residents. Graduated from that in 2005, and then started my full practice here at Valley Baptist as something called a hospitalist. And what that means is I'm board certified in internal medicine, and I would only take care of patients who were sick enough to be in the hospital. And so most of my training occurred in this hospital, and most of my practice has always been in this hospital. And one of the things that always impressed me the most about the way medicine's practiced in the Valley was how we treated patients when they were dying. When we couldn't fix the person's problems, which eventually that is always what happens, what could we do and how did we do it? And I always thought that was something we could do much better. And so when I became a hospitalist and started my practice, I spent a lot of attention to speaking to my patients about what's going on, providing a lot of education, and then always focusing on what we can do. Because honestly, there's always something we can do. And this is that quote that summarizes the essence of what palliative care is, and it's by a physician named Edward Trudeau, a late 19th century physician who took care of patients with tuberculosis. And medicine has changed a lot since then, but at its heart, it really shouldn't have changed. But along the way, especially in the last 20 years, as we came up with new machines and new medicines, I think physicians lost a lot about the importance of to comfort always. And we can cure sometimes, and these days, the miracle of modern medicine is we can cure a whole lot more things than we used to be able to cure. But we should also focus on the relief of pain and suffering. I can't always do it, but we have a lot of other great tools to relieve suffering. And unfortunately, we minimize the importance of that a lot. But again, that's the core of a lot of the reason why patients come to their doctors, is to make me feel better, but to comfort always. And this idea that patients or physicians, I heard too often say there's nothing we can do, is just breaks my heart. And I know what it did to my patients when they hear that. But there's always something we can do, even if it's to provide comfort. So that's a good starting reference for this talk and about what palliative care is, because Ms. Wasserman was telling me I should have come up with a different name instead of talking about palliative care, because nobody knows what palliative care is. How many people have heard of what palliative care is? Oh, see, I knew this. Well, I guess that's why you showed up to the talk. I guess everybody else should have been the ones to show up. So what is palliative care? It's the medical specialty or the philosophy of care that focuses on the prevention and relief of symptoms. To do this well, you can't just focus on the physical. To do this well, you have to focus on the emotional and spiritual components and the social components of illness that cause suffering. You have to recognize that it's the patient and their families and their loved ones who are going through this experience, not just the patient. And I don't think there's any one of us who makes decisions entirely in a void without taking into consideration the social implications, how it'll impact our families, the dynamics about dealing with illness and loss of function. Everyone around us goes into that decision making. Whereas a lot of times as physicians, we just focus just on the patient, and you miss the rest of that picture. Communication is extremely important. How we say things as physicians matters. And to have proper communication, you have to express the reality of the situation. A person needs to understand what you said and process that information so they can make good decisions. We've all heard of informed consent, but the heart of informed consent is the patient understanding all of their options and having all the information they need to make that decision. So as a physician, if I don't give you all your options and I present you with only options A and B, how can you have real informed consent if you don't know that you had other choices? And also trying to figure out various services appropriate at the setting of life's end. Palliative care isn't necessarily about the end of life or incurable illness, but that's something that we focused on a lot in our palliative care practice because so many patients, especially here in the Valley, do end their life here in the hospital, more so than almost any place else in the entire United States. And I'm not sure how many people were aware of that. So if we're going to be doing this, we owe it to our patients to do it well. So when we started palliative care with Valley Baptist, we focused it at first in the hospital. Let me help patients who are here in the hospital in crisis, because people don't come into the hospital routinely just for entertainment. It's usually because it's a crisis. I guess tonight's a little different, right? So, but it's in a crisis, and a lot of things are going on. Decisions are being made quickly and with a rapid pace. And new information's coming in. We're doing lots of tests. Who's explaining all of this? Who's helping guide the patients? And for the patients who are having severe crisis level symptoms, who's helping to relieve that pain and that suffering, whether it be spiritual, emotional, physical, social, who's working on that? Because a lot of the times the doctors are so busy working on fixing something that we ignore a lot of the other things going on. But we know that our patients value those other things as highly or even higher than cure. Whereas the doctors put the value on cure way up here, that's not necessarily where all the patients have it. All the patients, or a lot of patients, might have it as, hey, but I also don't want to be suffering. Who's going to focus on that? And that's what we try to bring to the care of the patient. Most people are familiar with hospice is, though. Most people that hear hospice think they know what that means. But it's not that simple. And the SAT version of this question of the way to put it is all hospice patients are getting palliative care, but not all palliative care patients are hospice patients. So palliative care will deal with patients who either it's kind of too late for hospice, or the real place where we can help a lot is if it's too early for hospice, because what Medicare would say is patients only qualify for hospice if they have less than 6 months to live. As a doctor, I've never been trained to figure out how long somebody has to live. There's no test, there's no x-ray. It's at best an educated guess. There's no class in medical school to determine prognosis. So if doctors don't really can't know the future, all we can do is give our guess based on tests and educated opinion, basically. How can I say a person qualifies for hospice? The government says 2 doctors have to declare that a person has less than 6 months to live. And as a result, a lot of physicians are very reluctant to refer a patient to hospice until they're absolutely sure a patient is dying. And the only time we're really sure is usually in the final days of life. And even then, we're not so good. What happens is, every community is very different about how they use hospice, but in our community, hospice is typically only used for the last few days of life. And that's a shame because it's a benefit that could last for months or years. Because what Medicare really is trying to tell doctors is hospice is an option for patients when they're possibly in the last 6 months of life, but you don't know for sure, when the most important thing for that patient is symptom relief and quality of life, rather than trying to pursue treatments to extend it. That's the full definition. That's what actually qualifies a patient for hospice. But still, they limit it to this last 6 months of life. Palliative care is at any point when a patient's dealing with a serious, potentially life-threatening illness. And I usually recommend it should start at the time of diagnosis. When you're dealing with a lot of these questions, I've been diagnosed with cancer. What does that mean for my future? What's going to happen? How should I plan? How am I going to be comfortable? I'm afraid I'm going to be in pain that can't be controlled. A lot of those questions come up at the time of diagnosis, and that's the right time to start talking about palliative care. So just to understand the hospice benefit a little bit more, because again, in our local community, I think it's not used enough. The data would say we're certainly not using it enough, or we're using it too late. But again, a patient who's in the last 6 months of life, maybe, according to the best opinion of their physician, if they choose not to change what's happening. Hospice doesn't try to speed anything up, that's for sure. It just focuses on providing symptom relief and improving quality of life. The hospice benefit doesn't have a copay under Medicare. It can be for years, potentially, as long as the patient still has less than 6 months to live. So I have patients in hospice sometimes for years, and they always qualify for it. And they've lived in hospice for years without needing to come into the hospital necessarily, without getting different medications, without getting a bunch of tests. It's just what was meant for them. Hospice includes whatever medical equipment necessary, medications for pain and symptom control, counseling, bereavement, spiritual support, social worker support, the physician who's an expert in pain and symptom management to help along with their primary care physician in addressing the patient's needs. All of these are included with no copay. And it covers hospital level support for short-term symptom control. And we started doing that in the Valley. The one healthcare facility we lack is an inpatient hospice unit, a freestanding hospice hospital, which is present in most other cities. We don't have anywhere in the whole Valley. So what most hospices have done is contract with hospitals to provide that inpatient care. And here at Valley Baptist in Harlingen, we've renovated a few rooms to be able to be larger, accommodate families, accommodate visitors, remove the visitation hours, work with nurses who are trained or more comfortable with caring for patients who need major symptom control, and that our palliative care team can help direct the care. That's what we've brought to the Valley over the past couple of years. It also covers respite, and it generally is provided in a patient's home. In the Valley, in our community, we also have a few hospice homes where a patient who has good symptom control needs 24-hour-a-day care, but just can't be done at home for whatever reason. And it's very complicated. That they can go to this hospice home, not be charged for it. It's a charitable thing. Have a private room rather than a nursing home. A lot of the times you have a roommate. And at the life's end, it's probably best to have privacy and dignity and comfort. And that can be administered in those facilities. The nearest one is in Olmito, and that's named Sunshine Haven. There's another in Weslaco named Aurora House, and another in McAllen named Comfort House. And those are typically nice safety nets to know that exist in our community. But we don't have an inpatient hospice, but it's part of the Medicare benefit. Again, it can go for unlimited periods of time as long as the patient still qualifies for it. Some patients come on hospice, they make a dramatic improvement, whereas I might feel now they have more than 6 months to live. It's okay to leave the hospice program and come back to it if things change. It's the kind of thing where you can go on and off of hospice depending on what's happening. And there's no penalty for that. And so what I would usually say is it depends most on what the patient wants rather than actually the prognosis. It far more depends on how the patient wants to be treated. So the difference, again, it's always appropriate to integrate palliative care. It's never really too early for palliative care. But hospice, palliative care really helps patients understand when it might be the most appropriate time to enter into hospice, since typically palliative care doctors work with hospice and know a little bit more about the benefit. So what exactly does palliative care do that's different than usual care? Well, one of the things is focusing on the relief of symptoms. And what most people know palliative care for is about taking care of pain. We're different than pain specialists. Pain specialists tend to focus more on chronic pain or using injections or invasive methods to control pain. Whereas palliative care focuses on many different symptoms, not just pain. But when we work with pain, we're working more with non-invasive, lower burden interventions like medications to treat chronic pain related to a life-threatening illness. But we also work with other symptoms beyond pain, like shortness of breath, fatigue, constipation, which oftentimes is a side effect of our pain medicines. Every medicine has a burden and a benefit, even palliative medicines. So if you look at medicines like chemotherapy, everybody knows the burdens of it or has heard about the burdens of it. But the benefit is either a cure for their cancer or to try to make it slow down or reverse or give more time. So that's the benefits. But there's this balance, and the balance keeps changing as a person's disease progresses. The same thing goes with comfort medicines, though, or pain medicines, where there's a burden to it. There might be nausea, there might be constipation, there might be fatigue, but the benefit is a relief of pain. And how to balance those is different for every patient. And every patient's very unique on how these medicines work. And everybody has different goals. And so as a palliative care doctor, I try to help understand those goals and help the patient express those goals so that we know how to treat that patient. So it's not the same for everybody. Loss of appetite, helping understand that and what treatments we have for it. Difficulty sleeping. All of these type of symptoms are some of the medical interventions that palliative care specialists can focus on. It helps patients gain that strength to carry on with daily life, improves their ability to tolerate other medical treatments. So it's not either or. It's not, well, you can have this or that. Why can't you have both? A lot of physicians are really focused on the cure part. Well, how about a specialist to help deal with all the other things that are really impacting quality of life? It benefits the patients and their families. And a lot of the benefits of the family, well, symptom control is always good. Your loved ones suffer along with you. If you're in physical pain, they almost feel your pain. But also that pain of not knowing the future, having lots of questions that haven't been answered, not knowing what to expect next. When I work with patients, it's usually patients and their families sitting down and having that discussion if the patient wants that. Usually people do. And help answer everybody's questions so that everybody can be on the same page or at least understand what the patient wants and understand what's to come, at least the best any doctor can explain it. That helps alleviate a lot of this uncertainty and that emotional distress that dealing with a serious illness causes to the patient and their family. And I keep mentioning goals of care, and that's really what it comes down to. But why is this important? Most people in the United States, if they were asked what's the ideal way that they can spend the end of their life, it's typically at home with good care, comfortable. But that's not what actually happens. We're all too often, about half of people in the United States die in hospitals. I think locally it's even higher than that. A quarter of people are dying in nursing facilities, 15% only in their personal homes, and 10% unexpectedly outside the hospital. So there's a tremendous disconnect from what most people would want in an ideal situation with what our healthcare system's actually delivering. And a lot of this has to do with uncertainty. A lot of this has to do with, we're generally considered a very death-denying culture, that we think that modern medicine can always fix things. But we definitely know that's just not the truth. Only about 40% of people who are dying received hospice care. And of those 40% who did receive it, it's usually for less than the last month of life. It used to only be about 20%. It's actually, hospice has become much more popular. But still, it's usually only occurring in the last few weeks of life rather than the full benefit, which potentially could be many months. And unfortunately, if a person is dealing with a terminal illness and the medicines are not working, if they're not in hospice, usually it means they're in the hospital or in and out of the hospital. And we know that that has a tremendous burden associated with it. The hospital is not, like I said, is not necessarily a fun place to be. And so if there's this disconnect between what's actually happening and what the patient would want, how do we help resolve this? We have a way to improve this. We have something like palliative care. And now that you'll see that most hospitals that are over 200 beds in size in the United States, about 70% of hospitals now have a palliative care team. In the entire Valley Baptist right now is the only one. That's pretty dramatic because we have a lot of hospitals. And right now we're the only one with a formal team here in Harlingen and in Brownsville. So, to lay it out as a diagram, the top model is really traditional medicine, unfortunately, where a person is diagnosed, we always try to cure, or fix, even if we can't. And it sounds odd, but even if we can't, this is what our reflex is. The first thing we're going to try to do is fix it. There's burden associated with this, and there's benefit associated with this. For every patient, it's different. For every disease, it's different. And at some point, we decide that a patient's dying, and we say that notorious thing, there's nothing left to do. And at that point, we refer to hospice, and then the patient dies. And then that's where we stop. This is not ideal. And this is a source of a lot of suffering. And we can fix that. Whereas at the time of diagnosis, it might be very important, or it might be possible to cure. Or we should definitely try. But eventually it won't be possible to cure. And we should always be talking about supportive care, about comfort, about relief of pain and suffering, always. I don't know any time it's appropriate not to address those things. Doesn't mean you necessarily need a palliative care specialist at that point, but definitely this should be discussed. As life progresses, palliative care becomes probably more and more appropriate, that we focus less and less on cure and more about quality of life. Because we know that our treatments have burdens, whether they be surgery or radiation or chemotherapy or whatever other medications, there's good and bad parts to all of them. And if the bad parts start outweighing the good parts, we need to be addressing that constantly. We can't wait till we get a crisis. And that's unfortunately the model we're in right now, where we wait for a crisis, that a person comes in the hospital, now we talk about it. And that's not necessarily the best way to do it. So if we can start palliative care earlier, maybe we can see that when the dying phase starts happening, that we're focused more on palliative rather than curative, that we're focused more on quality of life rather than trying to change what's happening. And there's a study that just came out last year from Harvard focusing on lung cancer. Very specific type of lung cancer that was already at stage 4. And they compared what happened when 100 patients got the usual Harvard cancer treatment versus palliative care plus the usual Harvard lung cancer treatment. The patients who got the palliative care lived 3 months longer, were less likely to be in an ICU, less likely to be hospitalized, less likely to get CPR, less likely to get chemotherapy, and lived 3 months longer. It was the first study that was done in a really good fashion to prove that common sense, or what we've been observing for a long time, makes sense.